Julia, thanks for the spectacular and overly generous introduction. Carl, thanks for the invitation. I was going to start out by saying a couple of things about Dr. Nace, but Julia has done it. And so in that time, in the time for this, I would like to instead congratulate again Al Lucier and Bill Benson and Gary Brown. They're just class acts and wonderful people, and I feel very comfortable coming back to Wills. And Julia hit the nail on the head. You're kind here. It's a nice place. It's a wonderful place. And it's also great ophthalmology and great teaching and education and research, all the good things. And it's great to be back. So I'd like to talk a little bit about the management of diabetic macular edema. I have no financial interests. And later today, there was to be more material on aflibercept, but it's not yet FDA approved. I'm not going to address it. I won't really be talking about new agents in development. But what I will be talking about is, for a minute or two, a few different tidbits on focal versus diffuse, and that the terms don't really have as much meaning as we'd like. Tell you one thing you might not remember about ETDRS laser. Tell you one thing to encapsulate something about steroids, and then spend more of the time on anti-VEGF things, on the DRCRNet trials and the Rise and Ride trials. And these are things I'm still learning and still trying to understand and still trying to remember. I like to have a pattern for how I take care of patients. So I like to pick a recipe and then try and follow it. Because then I have a chance of knowing what the outcomes might be and knowing what to explain to patients and knowing what's going on. And it takes a little thinking to remember these protocols. The Rise and Ride study is basically treating once a month with Lucentis, with ranibizumab. So if you're going to treat once a month, you can pay attention to that data. But if you're going to try and generalize and maybe treat sometimes and maybe not treat all the time, then it's a little bit more of a PRN type approach. And that gets more into the DRCRNet type arena, where there were rules and recommendations, but there were some decisions to make and some PRN type thinking. And that's how I usually take care of my patients. And so I'm going to spend a little bit more of the time on the DRCRNet approach. As far as the terms focal edema and diffuse edema, I think we picture in our minds something very specific, but it turns out if you're going to try and make a recommendation how to treat focal or how to treat diffuse based on some study, you've got to write down a definition of what focal is or what diffuse is. And when people try and write down those definitions, they get gibberish or they get 20 different definitions. And that was brought out in this very nice article in 2008 where there was a review of every big study that had been done to date, and they looked to try and see what the definition was of focal versus diffuse edema, and the conclusions were that the published definitions used in the method sections were very inconsistent. I thought there was another slide there, but basically, virtually all of the definitions differed. So although you might be able to picture one very specific end of the spectrum for focal edema and one for diffuse, when you get anywhere away from those endpoints of the ends of the spectrum, it gets hard to decide what we're talking about with focal or diffuse. So I don't talk about it as much as a lot of other people. The one teaching point I wanted to make about ETDRS laser is that it's actually better than we realize. So when we compare the results of the new studies and compare back to ETDRS findings, actually the ETDRS results would have been better if they treated patients like we're treating today. And let me show you why I think that that's so. So the ETDRS studied 4,000 patients about, and I think you remember the major result. The major result was that you could decrease moderate vision loss by about 50%, with the control patients losing moderate vision 22% of the time at 3 years, and the treated patient losing 13% or half as much. So you can reduce moderate vision loss by half. We also wanted to know how often the vision improved. And I think we got the sense from the ETDRS that the vision improved very infrequently. And that's why we tried steroids and other things. We were trying to get the vision to improve more. Only about 3% of ETDRS patients improved by 3 lines, and 17% had any improvement at 5 years. So I think we thought that virtually no one improves in the ETDRS. But the deck was stacked against that, because in the ETDRS, they mainly enrolled patients who were 20/25 and 20/20, and they couldn't improve. So that's what I want to show you. There were only about 15% of the patients could have improved in the ETDRS, and I'm going to show you the numbers. Here is the letter score at baseline. Here's the baseline exam and the number of patients with these letter scores. And if we translate it into Snellen vision, there are only 114 eyes that could have improved by 3 lines in the ETDRS. All of the other patients could not have improved because they were already at 20/20 and 20/25, and they could not have improved by 3 lines if you use that as a scoring rubric. So if you looked at the patients who were 20/40 or worse at baseline, how many improved? It's about 40%, so it's not quite as bad as you think. So if you start out worse than 20/40 in ETDRS, 40% actually improved by 3 lines. And here it is graphically, with 40% improving at 36 months in the treated group, and 25% actually improved that much in the deferral group. So doing nothing, actually, some patients get better too. Maybe they get better control, or maybe they have cataracts taken out or other things. So that was the tidbit I wanted to explain about the ETDRS. The tidbit to explain about steroids is that they wear off. I think you know that. You know they're effective. You know they wear off, and you know they had side effects. I'd just like to show you how quickly they wear off, over what time frame. And then you're going to have to re-inject, and when you re-inject, you're going to get more cataracts, more glaucoma, and more problems. So I don't use steroids that much. But there was a nice review and meta-analysis in 2009. And in LogMAR visions, when you have a negative number, you're getting better. So with LogMAR visions, negative numbers are getting better. This was every study that had been done to date looking at the 3-month vision following intravitreal steroids. And you can see for each of these studies at 3 months, patients are improving because you're in the negative range. You put them all together, and the error bar does not touch 0. So at 3 months, patients improve after intravitreal injection of steroids. But by 6 months, it's wearing off, and the error bar touches 0. So the meta-analysis of the IVTA data, basically, at least as of a few years ago, is basically that patients will improve for 3 months, and in months 4, 5, and 6, it gradually wears off. So you're going to need to re-inject, and with re-injection is going to come more side effects and downside. So I think that was another reason we got much more interested in trying to learn if anti-VEGF therapy would be helpful. This just shows the effect over time. With the LogMAR vision, minus is better, so at the 1-month visit, they're good, and 3 months and 5 months and so on, and it wears off over 3 to 6 months. So what's the new material? And the new material is anti-VEGF, Rise and Ride, and the DRCRNet studies. So I'm going to start out by talking about the major DRCRNet trial, and try and simplify it a little bit because it's complicated. And if you want to follow this recipe, you've got to be able to understand what they did and when to treat and so on. So this study had 4 groups: laser alone, laser plus ranibizumab, promptly. So the laser was done, I think, within 7 days, or deferred laser. So you had a ranibizumab injection and then no laser for the first 24 weeks, and then you could have laser under certain criteria, and steroids. And the 2-year outcomes have been published and found that ranibizumab and prompt or deferred laser is better than laser alone at 2 years. And here it is graphically. So patients gain about 8 letters. Here's the number of weeks. Here's 1 year and 2 years. And the top boxes are for the ranibizumab with prompt or deferred laser. And these are the IVTA and the laser alone groups. This is laser alone. This is the IVTA group. So note the behavior, of course, of the IVTA group. They get better. We predicted that. Then they get worse because they're getting cataracts. And the question is, once you take the cataract out, do they get enough better? And they do get a little bit better in the 2nd year, but either the cataracts are staying in or they're not getting better. So IVTA actually is a pretty good treatment if you're pseudophakic at baseline. So looking at this study, if they just looked at the pseudophakic at baseline patients, the IVTA patients do as well as the ranibizumab plus prompt or deferred laser. So if you're willing to accept the other risks of IVTA, it is simpler, it is fewer injections, it is cheaper. So IVTA for pseudophakics at baseline probably makes pretty good sense. So when you want to talk to patients about what to expect, we're going to do a combination of lasers and injections, and they sort of want to know how often do I have to come and how many injections and how many lasers, what's going to happen. Here's a way to summarize for them. In the ETDRS, when we just did laser, we were talking about quarterly visits, 3 to 5 lasers over 1 to 2 years. So that was what patients ended up with in the ETDRS, and 40% would get better. If you add ranibizumab to laser, you can get 60% better. So it's better, but how much more effort is involved in doing it? And over the first 2 years, instead of quarterly visits, you have monthly visits, averaging about 10 monthly visits in year 1 and about 7 to 10 in year 2. You're going to have about 2 lasers in year 1, and 30 to 50% will have 1 more laser in year 2. You're going to have about 8 injections in year 1 and 2 to 3 injections in year 2. I'm going to show you these numbers again in another table. If you want to follow this recipe, you have to know when to retreat, because there were some decisions to make. And it's not that hard to remember, although I can't remember anything. But it is complicated enough that in this study, the investigators actually logged onto some website and entered some information to figure out if they should retreat or not. So this is boiling it down to something a little bit simpler. If you're going to do Lucentis or ranibizumab plus laser, the recipe used in this study was to give it, this is a mistake, give it monthly, not weekly, give it monthly for the first 4 doses. So they had it monthly for the first 4 doses. And then the 5th and 6th dose would be given unless there was success. So you're going to treat 4 times at baseline, month 1, month 2, month 1, month 2, and month 3. And then the 5th and 6th dose would be given unless there was success. So now you have to remember what success means. And success is defined as 20/20 or OCT less than 250. So if you're at 20/20 or less than 250 on the OCT, you've got success. If you don't have success, you're going to keep treating. So you're going to continue treating if there's continued improvement, but still no success. Once there's success, you can stop. But if there's no success but continued improvement, you're going to keep treating. And what is improvement? Improvement is gaining a line or 5 letters, or reducing by 10% your OCT thickness. So for success, it's 20/20 or less than 250. For improvement, it's gaining a line or 10% better on OCT thickness. So if you've got success, you can pause, and you're going to resume treatment when you lose success. If you have no success but improvement, you're going to keep going. And if you have neither success nor improvement, you and the patient have to sit down and figure out what you want to do. So it's up to the patient and doctor to choose what to do. So that was more how often to keep injecting. That was the recipe on how to keep injecting. What about lasering? When are you going to laser? If you're going to use the prompt recipe, and I'm going to tell you in a minute that deferred probably is better, but if you're going to use the prompt recipe, the first laser was done within 7 to 10 days, although you might do it at the same visit and assume it will be the same effect. And then continue lasering every 3 months approximately if there's CSME. So you just have to remember the ETDRS every 3 months. If there was still CSME, despite the ongoing ranibizumab injections, do another laser. In the deferred laser, you didn't do laser for 24 weeks. So for the first 6 months, there were no lasers. You're just doing ranibizumab injections. And then at that point, if it's improving, you can keep doing ranibizumab injections. But if you have CSME and it's not improving, start doing laser. So you're going to defer the laser and start later. How many visits? What's the visit schedule that patients are going to have? In the first year, they're going to have it monthly. The recipe is monthly in the first year. If you have not needed an injection after 1 year, when you're in the second year, if you've not needed the injection for 3 consecutive visits, you could let it go longer. Instead of coming in a month, you come in 2 months. So if you've managed 3 visits without needing to do something, extend from 1 month to 2 months. And if you didn't need it at that 2-month visit, let it go even longer. Let it go to 16 weeks. So you could extend the follow-up to 16 weeks until you develop a need to repeat ranibizumab. So it's a little bit of treat and extend in the second year. So basically the 2-year data showed that combining laser and ranibizumab is better than laser alone and better than IVTA. But the question on the table then is, which is better, prompt or deferred laser? So should you start out with ranibizumab plus laser, or should you do ranibizumab and hold off laser and only do it later if needed? So which is better, prompt or deferred? The 3-year data is sort of helping us understand that. And the 2-year data showed, as I told you, that ranibizumab and laser is better than laser alone. But a point of including deferred laser in the study protocol is to help us try and decide if ranibizumab alone, sort of deferring laser indefinitely almost, would be reasonable. And the year 3 data just came out. It was published online in the last few weeks. And the year 3 data reports on eyes assigned to ranibizumab plus prompt or deferred laser. And those patients were continued in the same group to which they were assigned. So the recipe is staying the same for that. And if you were in the laser only or the IVTA groups, you're allowed to switch over to ranibizumab because that was better. And those patients are not really in the year 3 paper. The year 3 paper is focusing on the first 2 groups. So the year 3 report shows the outcomes for the ranibizumab plus prompt or deferred laser and allows us a hint at understanding if deferring laser indefinitely, in other words, using ranibizumab alone, is pretty good. So this came out online September 20th, the 3-year data. It's not been published yet in print, but it'll be coming out in print in the next few weeks. They had pretty good completeness of follow-up, 85 to 90%, had the 3-year visit. And for the patients I'm going to show you the comparisons for, their baseline characteristics were comparable at baseline in the 2 groups. So as far as the numbers of visits to expect, by definition, you had basically 13 visits in year 1 because you were coming every month. You had around 8 or so in year 2. In year 3, 7 or 8 visits is the number of visits that you're going to expect. So it's just a little bit less in year 3. As far as the number of injections, I already told you it was around 8 in the first year, around 2 to 3 in the second year. In the 3rd year, they only need 1 to 2 injections. So 1 to 2 injections in the 3rd year if you're following this recipe. As far as numbers of lasers, in the deferred group, less than half ended up needing a laser in the 1st year, and a few more had a laser in the 2nd year. So if you're in the deferred group, about half have it deferred for all of 2 years. About half have no lasers, but about half end up needing a laser by the end of 2 years. And in year 3, about 20% in each group, 25% in the prompt group got a laser, and 14% in the deferred group got at least 1 laser in the 3rd year. So you're sort of having a 20 or so % chance of having 1 more laser in the 3rd year. What about the visions? So these are the 2 groups, and at 52 weeks they're comparable, and at 104 weeks they were still comparable. This might be a spurious point how they come together, or maybe they're separating spuriously. Remember, this is a secondary endpoint. It's a subset of patients. The primary endpoint was at 2 years, and it's unclear if there's really a difference here, but there may be a difference, and there's a 3-letter difference favoring the deferred laser group at 3 years. So this is the reason that the paper ends up saying that if you're deciding between prompt or deferred laser, they might vote for deferred laser. At 3 years, you're a little bit better. The confidence interval does not include 0, and the p-value is significant. So at 3 years, the vision is better by about a half a line if you defer laser and not do it initially, promptly. And a whole bunch of secondary outcomes that they look at that are spelled out in the paper also favor the deferred laser group. So they're cautious in saying that deferred laser may be better. They don't say it is better because the study endpoint was at 2 years, and there are lots of caveats and changes and so on that went on. But basically, the data shows that the deferred patients did better than those treated promptly. The OCT thickness goes in the other direction. So the OCT data, it's thinner if you're in the prompt laser group. So usually the OCT data parallels the vision data, but here it's different. So the vision was better in the deferred laser group. The OCT thickness is better in the prompt laser group. So you are thinning out the retina more, but presumably somehow there's more damage because the vision is no better and actually a little bit worse. So the 2-year conclusions were that adding ranibizumab to laser is better than laser alone. you would use IVTA for pseudophakic at baseline. Ranibizumab alone was not studied, and bevacizumab alone was not studied. The 3-year data shows that although fewer injections are needed with prompt laser and the OCT is thinner, vision seems to be better if laser is deferred. So the suggestion is to defer laser, but the suggestion is not ranibizumab alone. These patients ended up getting some lasers. So if you're going to follow this recipe, start out with monthly injections and add laser if criteria are met later. But give it 6 months before starting with it. So what about ranibizumab alone? Because that's the next question on the table. They didn't really do a pure study of ranibizumab alone. Well, there were some clues that ranibizumab alone is pretty good. Here was a small study done, I think, at Wilmer. I think Kwam was the author. Peter will remember. And ranibizumab alone versus combined versus laser, a little bit better with ranibizumab alone. Here's a larger study. I'm going to slow down in a minute when I do Rise and Ride. Restore, a larger study. This had 100-and-something patients in each group. Ranibizumab alone, ranibizumab plus laser, and laser alone. And here you can see ranibizumab with or alone or with laser about the same, laser alone not as good. Again, you're getting about the same benefit. Here it was maybe 7 letters, 6 to 7 letters improvement. It was 8 letters improvement in the DRCR-NET study. The Resolve study, a large study, a smaller study than the last one. This was just ranibizumab versus sham, 0.3 or 0.5 milligrams, and in the 2 doses, 12 letters better at a year, 9 letters better in the 1 milligram group, in the 0.5 milligram group, and laser alone, no benefit. So these studies form the background for doing better big phase 3 registration type trials for ranibizumab alone versus laser, and that was Rise and Ride. So these 2 studies that Genentech sponsored, 2 phase 3 trials. Subjects were randomized to monthly ranibizumab versus sham. Rescue laser was allowed. So this is not a PRN thing. There's not much decision-making here. If you're going to follow this recipe, inject every month. If you're going to start deciding and trying to figure out what to do, maybe drift back to the DRCR-NET guidance. But this is an inject every month strategy for the first year. 375 patients enrolled in each arm and in each study, randomized 1:1:1 to no drug, 0.3 milligrams drug, 0.5 milligrams drug, and a 24-month outcome for the primary outcome, monthly injections. And you know the results. It worked, and the drug is FDA approved for this indication. At 2 years, there's a 12-letter improvement with 24 approximately monthly ranibizumab injections, and 11 or 12 letters in RIDE, so same thing. And for the anatomic findings, you can see with the 2 different drug doses, you get down to 250 micron thickness in both studies, and with laser alone, you lose half as much thickness. So laser alone doesn't work as well. About 40% gain 3 lines versus 15% with sham. In the sham group, you're allowed to have some, in both groups, you're allowed to have some lasers. Safety data showed no real new findings. The only important point in the safety data was that there were fewer AEs and SAEs in the 0.3 milligram group as opposed to the 0.5 milligram group. The FDA has a general prejudice that if things seem to work equally well, they always want the lower dose. So this is why the 0.3 milligram dose got approved, as opposed to the 0.5 milligram dose. So now there are 2 different doses of Lucentis, and the fellows and residents and nurses and the staff have to be real careful when you're picking that out of the Pyxis to pick out the 0.3 milligram or the 0.5 milligram and don't misdose your patient. As far as how many lasers to expect over 2 years in Rise and Ride, in the no drug group, they got about 1.5 to 2 lasers. So I think they were under-treating. This is why it's not a real crisp study of like a redo of, it wasn't ETDRS laser versus monthly injections. I think it was underdosed laser versus monthly injections. You would have expected more lasers, I think. So they had about 1.5 to 2 lasers if there was no drug. If you got drug, you got about 1 laser. in 2 years. As far as avoiding neovascularization, using PRP as a marker for did high-risk PDR develop, it developed about 10% of the time if you're not getting ranibizumab, and it basically doesn't develop if you are getting ranibizumab. So that's nice. You can avoid proliferative disease. What I worry about is the patient who stops coming or misses visits and come back 3 or 4 months later with a blow-up of PDR, and Tom Fezen is nodding his head. We've all seen that. We actually all see that even more in central vein occlusion. When you're giving monthly injections with central vein occlusion and then they break their leg and miss 3 visits and they come back with marked iris neovascularization and neovascular glaucoma. So you might want to be doing a gentle PRP in some of these patients anyway while they're coming, but that's a different discussion. So patients, at the end of all this, ask us, what can I do to see better? They ask you that every day. And what I would say is add anti-VEGF to laser, and on average you're going to see about 2 lines better than you would have if you had just done laser alone. But I also, and this is a different lecture, recommend seeing an expert in diabetes care management. And this gets touchy because I'm talking about not seeing their family doctor, who usually doesn't know which diabetes drug is better these days, how to treat the hypertension. It is really complicated, and it turns out it makes a difference. And there are all kinds of papers that show that not only is better control better, but there are certain ways of managing the diabetes systemically that equate to better ophthalmic outcomes. So I would really emphasize the importance of optimizing systemic care. Doing all this is going to improve quality of life and vision, but probably costs a little bit more too. And Bill Smeedy did a nice summary article on that, showing that when we do some of these things and spend more money, we're getting better outcomes for it, but at least in the short run, it's more expensive. In the long run, it may be less expensive because you're avoiding disability, they can keep working, and you're avoiding payments to the blind and so on. So I thank you very much. It's a great treat to come back and see old friends. It's a great treat to have a chance to salute Dr. Lucier and Dr. Benson and Dr. Brown, who I grew up with and taught me everything, including Dr. Tasman, who taught me even more, and Julia Haller and Carl, who are teaching us all the time, every day now. So thank you.